So much attention on opiate overdoses, it seems especially bad timing for the Food and Drug Administration to approve a highly addictive, potentially deadly drug. That's how some experts are describing the painkiller Zohydro, set to hit the market in the coming weeks. The capsules will contain up to 50 milligrams of pure hydrocodone, 10 times more than a regular Vicodin. That means an adult could overdose from ingesting just 2 of the easily crushed capsules, and 1 pill could kill a child. Adding to the outrage, the FDA approved the drug even after an advisory committee voted 11-2 against it. Now, 40 of the nation's biggest healthcare and drug treatment groups have sent a letter to the FDA Commissioner Margaret Hamburg urging her to revoke approval of Zohydro. So is this drug dangerous or unnecessary? Judy Foreman is a nationally syndicated medical journalist who spent 23 years as a staff writer for the Boston Globe. She's also the author of the book A Nation in Pain, Healing Our Biggest Health Problem. Welcome to Greater Boston.
Thank you.
Judy. So part of this is that the panel recommended against this Zohydro, and the FDA went ahead and approved it. So is that unusual?
That is unusual, but the FDA had also previously written a report saying that they should approve it because it seems to be safe and effective and ought to be one of the choices on the market. So it's a very confusing situation.
And you're one of the people who thinks it should be.
I actually do, mainly because, you know, there's 100 million people in pain in this country, in chronic pain. Not all of them need the opioids, obviously, but many do, and all the emphasis on the painkiller abuse is making it harder for the real pain patients to get the drugs they need.
I mean, that's the essence of this. This is for people with chronic, persistent, unstoppable pain.
Exactly.
It could be lower back pain or something like that. So if you ban this, it leaves that group without, and all the outrage has to do with the fact that, and yes, we have seen a huge uptick in the abuse of it, but there's got to be a way to control that.
Yes. I mean, there's sort of like 2 separate populations. There's the pain patients who generally don't get addicted, don't keep upping their doses, basically take the drugs responsibly, sometimes for years, and they do fine. The drugs allow them to do their lives. And then you have the people who have a different disease, addiction, and that's a real disease as well. But they're the ones who are likely to abuse them and divert them from legitimate medical purposes to their own addiction.
Those people are taking them not because they need them, because it's
feeding their addiction,
and they're raiding somebody else's medicine cabinet.
Exactly. Exactly. And it really creates a huge access problem. The advantage of Zohydro, as I understand it is a single entity drug. It only has hydrocodone in it. It doesn't have anything else like acetaminophen. That's perceived to be the problem with Vicodin because it has both. And even though it seems hard to believe, it's the acetaminophen, which is the main ingredient in Tylenol, that makes the Vicodin a problem, not the opioid itself.
I think one of the problems is that people are very suspicious of the pharmaceutical companies these days and their motivations, and maybe they want people to get addicted to it, and they're nervous about that.
I think they want to make money.
Well, that too. But the more people have to take it, the more money they're going to get.
Yeah, although in defense, and I take no money from any drug companies or anybody, but they have been trying to make abuse deterrent formulations, but that turns out to be its own problem, because if something that you're not supposed to chew or snort or inject, then people do turn away from that and go to heroin. So it's really a complicated problem.
Yeah, that's actually something that Representative Bill Keating was suggesting.
Yes, I mean, but you can't totally blame the uptick in heroin on regular pain patients. They're not the ones driving the heroin epidemic.
How many people, I know you've written about this extensively, how many people does chronic, persistent pain really affect in the country?
100 million. And
100 million?
100 million. It's about, I know, people are skeptical. They don't all have excruciating pain, but they have some degree of chronic pain. That's actually more than people with cancer, heart disease, and diabetes all put together. And the current research shows that chronic pain is actually a disease in its own right, a disease of the nervous system. It's not just a symptom of something else. So the figure is big.
Do these things work for that? I mean,
somewhat. Opioids are not a slam dunk. They usually reduce pain 30 to 40%, which doesn't sound like much, but if your pain is at a 10 on a scale of 10 and it gets you down to a 6, you can do your job.
Now, is this as addictive as, say, something like fentanyl? Does it give you the same?
All the opioids.
Have you tried any of these, by the way?
Well, I had really serious neck
as
pain.
Research.
As purely as research. No, purely as, because I was in this 100 million and at the far end with really extreme neck pain for a while. Yeah, I took oxycodone. It helped some, but not a lot. A lot of pain patients hate these drugs. They don't like the side effects.
They make you logy and
logy, very constipated. They're no fun. I mean, people only take them if they're in pain and they don't want to get high. They just want the pain to go away. But there's a difference that some of these doctors who are opposed to opioids don't really make, and that is there's a difference between addiction and dependence. A lot of pain patients do become dependent on opioids, but they live their lives. They don't keep upping their doses. They don't abuse them. Addiction is really a primary neurological disease which involves the abuse.
Is part of the problem the way they are prescribed, too? I mean, is this a drug that somebody should have to go back and get all the time, as opposed to, you know, a prescription that lasts you a year?
Well, that's one of the issues, is what schedule of this government federal schedule should it be? If it's in Schedule 2, which is pretty restrictive, you have to go back every few months and get it, as opposed to something where you can get more refills. That's a problem in and of itself. There's another piece of this that sort of never gets mentioned, which is methadone, which is actually a much more troublesome drug. It actually causes a third of the opioid overdose deaths, and doctors don't know how to prescribe it, but they're being forced to by a lot of states because it's so cheap. They're moving a lot of Medicaid patients to methadone instead of the other drugs, and it has a very short window of effectiveness, but a long window that it stays in the body. So people stop getting the benefits, they take it again before they should, and they often end up dying.
Has the FDA ever reversed itself on something like this? I know they've taken drugs off the market, like Fen-Phen and that kind of stuff. It
is rare for them to go against the advisory panel, but as I say, the FDA did have its own report showing that Zohydro seems to be safe and effective and should be on the market. So there's a lot of struggles within the FDA over this.
And what about people prescribing it? I mean, would this become rampant? Because as soon as people hear about something like this, they're going to say, I want to try the next thing up.
The big problem is doctors don't get enough pain education in medical school, so they really often don't know how to prescribe this stuff. So they end up overly fearful of prescribing it to some people and overly hesitating to prescribe it to others. And that's another problem.
All right, Judy Foreman, thanks for your expertise on that.
Thank you.
Appreciate it.